Today I'll be talking about Achilles tendon injuries. Achilles, the name itself, is originated from the legendary warrior in Greek mythology who had died as a result of an injury to the mid portion of his Achilles tendon. Achilles tendon injury is referred to the either rupture or tendinopathy. Men are more prone to get Achilles tendon injury compared to women. There are multiple risk factors that can be associated with Achilles tendon injuries. For example, elite level athletes, weekend warriors, and older patient. Older patient, they have reduced tendon integrity, and which can increase risk for Achilles tendon injuries. Patient with comorbid such as diabetes, end-stage renal failure, and hypoparathyroidism also can have high risk of Achilles tendon injuries. Steroid injection and fluoroquinolone antibiotics also have risk for Achilles tendon injuries, especially rupture and other risk factor includes overpronation of the foot, reduced calf flexibility, and restricted dorsiflexion, and also sudden change in training pattern. For the anatomy, Achilles tendon is the largest and thickest tendon in the body. It is formed by combination of the common tendon of gastrocnemius and soleus muscle, and inserts onto the posterior surface of the calcaneus. The plantaris tendon also fused with the medial side of the Achilles tendon, proximal to its attachment site. The blood supply for Achilles tendon is from the posterior tibial artery. There are two bursa in the Achilles tendon, which are the subcutaneous calcaneal bursa and also deep retrocalcaneal bursa. For the clinical presentation, in the history, for tendon rupture cases, usually patient will be presented with traumatic event or non-traumatic event. They will complain of sudden acute pain in the Achilles tendon with an audible snap. Usually, they often describe as like being kicked at the back of the leg, or like being hit at the back of the leg. Usually, patient with acute rupture will also have a subsequent weakness and difficulty to ambulate. In the case of Achilles tendinopathy, usually patient complain a gradual development of symptoms, and typically complains of pains and morning stiffness. In early stages, usually there's a gradual development of pain and stiffness at rest, and the symptoms usually improve with exercise. As the disease progresses, the pain might be presented with the after exercise, and finally pain with the exercise. For physical examination, usually patient will have antalgic gait and difficulty to ambulate. We can do a few functional assessment to reproduce the pain, such as lunges, hops, and double or single leg calf raises. On inspection, usually we do in prone position. We can there might be swelling over the Achilles and also calf muscle atrophy. On palpation, there might be local tenderness over the mid portion or at the insertional site of the Achilles tendon. There might be palpable gap in the case of complete tendon rupture, and the entire length of the gastrocsoleus complex should be palpated because the rupture can occur anywhere from the musculotendinous junction to the insertion at the calcaneus. Lateral and medial tenderness usually associated with retrocalcaneal bursitis. For the RM, there might be limited active plantar flexion and passive dorsiflexion. For RM, there might be limited active plantar flexion and increased passive dorsiflexion in the case of complete rupture. There are a few passive movements that we can do to elicit the pain. For example, gastrocnemial muscle stretch and also the soleus muscle stretch. For the special test, we can do Thompson test. It is performed by squeezing the calf. The test is positive when the foot is unable to plantar flex. It is usually positive in the partial or complete rupture. The differential diagnosis for Achilles tendon injuries includes retrocalcaneal bursitis, Haglund's disease, posterior impingement syndrome, and posterior calcaneal bone fracture. For the imaging, we can do X-ray and lateral ankle view to rule out Haglund deformity or avulsion fracture. X-ray also can show calcified tendon in the case of Achilles tendinopathy. The best imaging is ultrasound. We can to look for any discontinuity of the tendon in the case of complete rupture, and we can also measure the gap with the foot at the neutral position versus 20 degree of the plantar flexion. In the case of Achilles tendinopathy, ultrasound also can be used to look for any neurovascularization of the tendon. MRI usually not indicated for acute rupture, but as the physical examination is more superior to make the diagnosis. MRI can be done for the Achilles tendinopathy to better classify the degree of degeneration present in the tendon. For the treatment, it can be either operative or non-operative. In the case of acute Achilles tendon rupture, there's a study show there's equivalent recurrence rupture rates and no clinically important difference in measured outcomes between operative and non-operative. In fact, there's increased complication rates in the operative groups. For non-operative management of acute rupture, we can use price principle for starting with protection, rise, ice compression, and elevation. And then we can start equinus immobilization for 2 weeks with cast or brace while the foot is in 20-degree plantar flexion with strictly non-weight bearing. And then we followed by progressive weight bearing with heel lift and ROM exercise with dorsiflexion blocks during the next 4 to 6 weeks. And then exercise program, and then we can initiate the exercise program including transition to footwear with a heel lift, open chain exercise, and focus on eccentric strengthening with eventual resistance exercise at about 10 weeks. For cases of Achilles tendinopathy, usually we use a flexion protocol for 6 to 12 weeks with maintenance exercise for 6 to 12 months. In a flexion protocol, there are 2 key exercises, which are gastrocnemius drop and soleus drop. In gastrocnemius drop, we start the exercise with demi-point position with heel raised and the knee is fully extended, and then the heel is slowly going down until it goes level to the ground. It goes parallel to the level of the ground. In soleus drop, started with a demi-point position where the heel raised but the knee is flexed at 45 degrees. And then the heel slowly going down until it becomes parallel to the level of the ground. In a flexion protocol, usually we advise patients to do 3 sets of 15 reps for 2 times per day, 7 days a week for 12 weeks. And then we slowly we can progress this with exercise by increasing the weight. So we can add the weight in the backpack, or we can use the dumbbell. For operative management, usually it is done for acute rupture. It can be done either primary open repair or percutaneous repair. For post-op management, we use the same rehabilitation protocol as we use for non-operative management for acute rupture. Limb motion and early weight bearing have been shown significant increase functional outcomes and health-related quality of life. Thank you.